hospital actually.
So, okay, doctors, we are starting the session for today. I request the attention of all the respected faculties and delegates. Kindly allow me a few minutes of yours and let me introduce myself and introduce faculty members of the session. Good evening and welcome to one and all. I am Rituparna from Clarinet, the designated session assistant for a seamless experience, and Clarinet is India's most trusted and widely used digital platform with multiple enriching services exclusively for the doctors. Clarinet is very proud to be a digital partner for this 21st episode of online lecture series organized by the Society of Onco Anaesthesia and Perioperative Care, e-education. And the sensational topic for today is anesthesia for esophageal and upper gastrointestinal oncosurgery. Now, without wasting any further minute, let's begin today's session, for which I would like to invite Dr. Jyotsna Goswami, the Honorable President of Society of Onco Anaesthesia and Perioperative Care, to coordinate further. Over to you, ma'am.
Good evening. Good evening, everyone, for this 21st session of SOPC webinar. And today we have a very interesting topic, an important topic, the anesthesia for esophageal surgery and upper GI oncosurgery. And for that, we will have a very experienced speaker and chairperson. So I'll invite our today's chairperson, Dr. Punita C., who is an associate professor in Department of Anesthesia, Pain and Palliative Care, Cancer Institute, Adyar, Chennai. And her special interest is in onco anesthesia and interventional pain management. So over to Dr. Punita. Please start the session today.
Good evening, everyone. I thank you all for this opportunity again. We are all very excited to share what we know with you all. And I would like to introduce our speaker for today, Dr. Nivedya. She's an associate professor in our department. She has been with us for around 9 years now, and she has wide experience, and she has an added qualification in nutrition, especially in onco patients. Over to you, Nivedya.
Yeah, good evening, everyone. I think we should, yeah, I'm trying to share, yeah. So, yeah. Are you all able to see my slides?
Yes, yes. Can go on.
Right. Just a minute. Yeah. So we'll do this topic on anesthetic management of esophageal and gastric cancer surgery today. Yeah. So the GI cancers, they comprise a heterogeneous array of tumor types. They are the common GI cancers and the less common GI cancers. The common GI cancers include the colorectal cancer, the gastric, the hepatobiliary, the esophageal, and the pancreatic. The less common cancers are the anal cancer, the pendicular, the gallbladder cancer, the small intestine cancer, the GI net, and the GIST. The International Agency for Research on Cancer released the Global Cancer Burden in 2020, and we found that more than 5 million people were diagnosed with the most common GI cancers, and more than 3.5 million people died from the most common GI cancers. So in the rank order of cancer incidence, colorectal stands 3rd, gastric stands 5th, and esophagus stands 8th. Now moving to the anatomy of esophagus. It is a long muscular foot pipe, 18 to 26 centimeters long, extending from C7 to T11. The gastroesophageal junction corresponds to the xiphisternum. 4 anatomic areas. The esophagus can be divided into 4 anatomic areas, namely the cervical, the thoracic, the lower thoracic, and the abdominal esophagus. So the blood supply is also divided into 3 areas. The blood supply of the esophagus in the neck, it is supplied by the inferior thyroid artery, the vertebral arteries, and the carotid artery. In the thorax, the esophagus is supplied by the bronchial branches from the thoracic aorta, the esophageal branches, and the intercostal arteries. In the abdomen, it is supplied by the left gastric artery and the short gastric artery. Regarding the relationships, the neck esophagus is related to the recurrent laryngeal nerve and the carotid artery. In the thorax, the esophagus is again related closely in the anterior aspect with the trachea, with the arch of aorta, the pericardium, the left atrium, the left main bronchus. Posteriorly, it is related to the anterior wall of the aorta, the posterior intercostal arteries, the azygos, the hemiazygos vein, the vertebral column, the longest colli muscles, also the thoracic duct. So we have two high pressure zones, the upper and the lower esophageal sphincters. They prevent the regurgitation of food products. Now the slight section of esophagus, the mucosa is lined by the epithelium, the non-keratinized stratified squamous epithelium. Esophagus doesn't have a serosa, it only has an adventitia, so it enables early spread of tumors. Now coming to the GI cancers, the esophageal cancer, the commonest major types of esophageal cancer are the squamous cell CA and the esophageal adenocarcinoma. The other less common cancers are the small cell CA, the sarcomas, and the melanomas. Now, the squamous cell CA occurs mainly in the upper and the middle parts of the esophagus. The adenocarcinoma usually occurs in the lower part of the esophagus. While squamous cell CA has a high incidence globally, adenocarcinoma has a higher mortality rate. Looking into the pathophysiology, esophageal squamous cell CA, it is usually a squamous dysplasia, mainly due to smoking, alcohol, or thermal injury, causing early squamous cell CA and an invasive squamous cell CA. While adenocarcinomas, which occur at the squamocolumnar junction, is usually due to an acid biliary reflux, especially in the obese patients, resulting in Barrett's esophagus, causing dysplastic Barrett's and esophageal adenocarcinoma. Now, the difference in the histological subtypes includes that adenocarcinoma is more common in the Caucasians, but squamous cell CA is more common in the Africa and East Asia. While dietary habits, adenocarcinoma, it includes a risk because of alcohol. There is low dietary intake of fruits and vegetables. However, in squamous cell CA, it is mainly due to salted vegetables and preserved fish. So adenocarcinoma is a disease of the developed world, but squamous cell CA is a disease of low socioeconomic status and developing world. Now, clinical presentation would include two spectrums. It would be a dysphagia, odynophagia, weight loss, or severe GERD. So we'll have to do a local tumor examination and look for distant mets, and also look for investigations that will enable us to find out lymph nodes and distant mets. Now, the surgeries that we offer for esophageal CA includes the transthoracic esophagectomy, which can be an Ivor-Lewis incision or McEwen's incision, which is a triple incision in a transthoracic esophagectomy. It can also be a transhiatal esophagectomy or a minimally invasive surgery like Watts and Ramey, or you have an endoscopic excision, which is an esophageal mucosal resection or esophageal submucosal dissection, which is for T1A, N0, M0 lesion. Now, looking into the incisions, transhiatal esophagectomy would be midline laparotomy and left cervical incision. There is a risk of tracheobronchial injury, bleeding, cardiac compression, and arrhythmias because the dissection in transhiatal esophagectomy in the mediastinum is blind. While transthoracic esophagectomy, which are the Ivor-Lewis or the McEwen's incision, will include a midline laparotomy, right thoracotomy in Ivor-Lewis. In McEwen's, it will also include the left cervical incision. In either case, you would have to provide one lung ventilation and pain control on early extubation. While minimally invasive esophagectomy would say right thoracoscopy, laparoscopy, and left cervical incision. There is risk of aspiration. One lung ventilation is essential, and the procedure duration would be taken into consideration because they may be long procedures. Now, the advantages and disadvantages of TTE, transthoracic esophagectomy, and transhiatal esophagectomy. Transthoracic, there may be increased chance of postoperative pulmonary complications. The port site pain has also been noted. Mediastinal leak is another complication. While you have direct visualization of an exposure of the thorax, the recurrent laryngeal nerve injury is relatively lesser compared to THE, where the recurrent laryngeal nerve injury is slightly higher. There is also increased likeliness of stricture formation and poor visualization of the middle esophagus in THE. However, postoperative pulmonary complications are lesser as compared to a TE in THE. The neck anastomotic leak is still manageable. So there is an urgent unmet medical need for early diagnosis, preoperative anesthetic management, prehabilitation, intraoperative management, and postoperative management. So the preoperative assessment for esophagectomy would include the basic assessment, habits like smoker or alcohol, looking for weight loss, looking for malnutrition, frailty, anemia, any associated illness like COPD, liver cirrhosis, and then looking for pain. And then there is something called the Assess Respiratory Risk in Surgical Patients in Catalonia, which is the ARISCAT score, which has a high sensitivity in predicting pulmonary complications in the in-hospital period after surgery, after thoracic surgery especially. And that includes parameters like preoperative SpO2, age, the surgical incision, whether it is emergency or an elective surgery, hemoglobin, whether the patient had recent history of URM or an LR. Then would include airway assessment. You will look into the height. You will also see the CT to know what particular DLT you would be using. And then there are some special scenarios if the patient already has a difficult airway or a tracheostomy in situ. And also look into the endoscopic report and the status of the vocal cord and the esophageal lumen, and if the patient has diverticulum or esophageal pouches. Then coming into the cardiac evaluation, we will need a resting ECG, exercise ECG, and echo. Now, cardiac complications is a conglomeration in esophagectomy. It can happen due to several reasons, mainly due to difficult airway, intraoperative blood loss, arrhythmias, injury to the lung or vessels while doing the surgery, postoperative pain, and one lung ventilation. Pulmonary investigations would include a basic chest X-ray, pulmonary function tests. Now, if the forced vital capacity is greater than 80%, that is normal. And FEV1 to FVC ratio, which is the FE1%, if it is reduced, it can be obstructive. If the ratio is normal, it can still be normal or restrictive. Now, PFT predicts the degree to which pre-existing obstructive or restrictive components of PFT, pulmonary function, may compromise the ability to ventilate adequately and maintain clear lungs after thoracic surgery. Now, this particular study in the Netherlands identified that DLCO, which is done exclusively in TTE and THE in a single center on 459 patients on esophageal CA. They identified that DLCO was an independent predictor of major complications, which were defined as clavin endo 3B or. So it doesn't, however, the study doesn't talk if the surgeries were minimally invasive, and DLCO was the strongest predictor of major complications in the study. So reduced DLCO would implicate a restrictive lung disease or an obstructive lung disease. It could be a pulmonary vascular disease or an intrinsic lung disease. Now, 10 seconds of breath holding required for DLCO maneuver is easier to perform for most patients than a forced exhalation required for spirometry. Now, regarding CPET. CPET is a useful tool in this particular study on esophageal CA. They use CPET to assess risk in patients who were undergoing surgery for esophageal and gastric cancer. This is again a single center, 200 patients, prospective interventional cohort study. And they identified that the anaerobic threshold level below 11 ml per kg per minute was highly predictive of cardiovascular complications. And again, anaerobic threshold levels less than 9.5 had the best predictive accuracy of major perioperative cardiac complications. So they concluded that CPET is a useful perioperative risk assessment tool for patients undergoing surgery on esophageal and gastric complications, and it carries a particularly high risk for cardiovascular complications. Now, along with the assessment, we need to go hand in hand with the treatment for the patient. So that would include preoperative treatment of GERD. So we need to treat the patient with H2 receptor antagonist and proton pump inhibitors, which will reduce gastric volume and acidity. It will also reduce the incidence of pneumonitis if aspiration is likely to occur. Next would be the preoperative nutritional support. So this is essentially diagnosed or assessed using a qualified dietitian. So you see for weight loss more than 10 to 15% in previous 6 months, the BMI if it is less than 18.5 and serum albumin less than 3, and aim for an energy and protein intake of at least 30 kilocalories per kg per day and 1.2 grams per protein per kg per day in patients receiving radiotherapy or chemotherapy. And in patients for surgery, at least aim for 1.5 grams of protein per kg per day. Now, looking at neoadjuvant chemotherapy, patients who are in the cross-trial, that would be the chemoradiotherapy for esophageal cancer, followed by surgery study, in which patients invariable of squamous cell CA or adenocarcinoma are given weekly paclitaxel and carboplatin and concurrent 183 centigrade of radiotherapy for 23 days, which would come to 41.4 gray of RT. Or it could be that adenocarcinoma who are not in the cross trial are also given 5-fluorouracil, leucovorin, oxaliplatin, and docetaxel, which is the FLOT or the Capiox. Now, the implications of chemotherapy are very important during the pre-anesthetic assessment. We should remember that these kind of drugs like oxaliplatin and 5-fluorouracil can cause arrhythmias. Oxaliplatin especially can cause QT prolongation. Thrombophlebitis and difficult venous access is another complication that we usually come across. And then you have delayed myelosuppression with carboplatin, especially after 3 weeks. And this myelosuppression is associated with thrombocytopenia. Neuropathies are again common with Taxol. And again, 5-fluorouracil can cause angina because of coronary vasospasm during the chemotherapy. So we should also ask for history of angina during chemo. Then there is always a risk of tumor necrosis and perforation with any chemotherapy. So the patient will land up with, say, a gastric cancer patient can have a gastric perforation, and then he would come in for surgery, emergency laparotomy, and he would land up in the post-operative period in the myelosuppressive stage of chemotherapy. Now, consequences of radiotherapy. So within 2-3 weeks of radiation, we would have mucosal inflammation and esophagitis. Because of the esophagitis, the patient will have esophageal narrowing and pudinophagia, resulting in reduced food intake, which is worsened with concurrent chemotherapy. There is always a chance that the patient can develop tracheoesophageal fistulas. Hypothyroidism is a complication that occurs 1-2 years after radiotherapy. Radiation-induced pneumonitis is usually localized. It settles with low-dose steroids. It is a complication after 3 to 6 months of radiotherapy. Radiation-induced cardiac insults is a late complication occurring after 5 to 6 years, and you see insidious ECG changes and pericarditis. Now, myelosuppression is also a complication of radiotherapy, which worsens with concurrent chemotherapy. So preoperatively, we must optimize the patients. You should ask them to stop smoking, correct anemia, and support the patient with nutrition. Now, patient can be malnourished or can be obese. So supplementation before operation is indicated where patients fail to take 75% of their goal calories, and tube feeding is indicated for patients with deficiencies of 50% or more. And you should also encourage them to do spirometry. Now, a bit of pharmacology. Now, there are some drugs that can reduce the lower esophageal sphincter tone, which includes our own opioids, antidepressant medications, and beta-adrenergic agonists. And there are drugs which can increase the sphincter tone, which includes the anticholinesterase, the metoclopramide, metoprolol. Now, salient points during induction and intraoperative management of esophageal surgeries include use large IV bore cannulas, pre-oxygenate the patient, use general anesthesia, always supplemented with regional anesthesia. You will probably use a tracheal tube or a left DLT or a bronchial blocker. Fix the NG tube before surgery, which is of paramount importance. Then you will need to protect the patient while positioning, and probably you will have to change the left DLT back to endotracheal tube in between, and preferably it is better to extubate the patient in 50. Now, during induction, the esophageal masses, the masses of esophageal origin, which are posterior mediastinal masses, they can, and the dilated esophagus itself can impinge on the airway and can cause obstruction. And trachea is very easily compressed posteriorly because of the lack of the cartilaginous support. And the posterior compression can result in expiratory obstruction. Now, rapid sequence induction strategy can be followed for obstructive masses and dysmotility syndromes. And optimal fasting guidelines for gastroesophageal pathology is still unclear. Now, we have a few controversies with cricoid pressure. Now, cricoid pressure, which is applied on the cricoid cartilage, can even cause lateral displacement of the esophagus or incomplete compression of the esophagus. It can also displace and compress the airway. It is also associated with decrease in lower esophageal sphincter pressure, causing passive regurgitation in the anesthetized patient. So, decision to apply Celix is individualized. What about awake intubations? Serious consideration should be given to intubation in the awake patient, particularly for patients who have high risk of aspiration, those presenting with achalasia. Now, those presenting with achalasia also have 0.5% risk of malignancy of the esophagus. High-grade esophageal obstructions and those requiring emergency procedures with full stomach. It is better to keep these patients on head and elevation to 30 degrees to prevent reflux and regurgitation and minimize aspiration at any time. So appropriate pre-operative suctioning of the NGT, if present, is ideal. So we need to isolate the lung during the surgery, use left DLTs, the bronchial blockers, or the endotracheal tubes. Always better to do a check bronchoscopy before tube insertion in case of subglottic stenosis. Now, patient positioning, one lung ventilation, surgical manipulations can alter ventilation and perfusion from the dependent and the non-dependent or collapsed lung. Now, monitoring during esophagectomy would include all the essential monitors, including an arterial line and arterial blood pressure to identify hypotension during manipulation. And you have a wide spectrum of regional anesthesia choices. Epidural would be the gold standard, and paravertebral is equally good. Now, the significance of pain relief. The good intraoperative pain relief could prevent postoperative chronic pain. Poorly managed thoracotomy pain can result in postoperative pulmonary complications. Role of NSAIDs and paracetamol in thoracotomy is twofold, can reduce the opioid requirements, and it also treats ipsilateral shoulder pain, which is resistant to thoracic epidural anesthesia. Now, a study which was done in Italy between March 2012 and November 2013 on 84 patients in esophageal CA. It's a prospective cohort study, identified that hypotensive episodes may be associated with postoperative esophageal anastomotic leak. The hypotensive episodes were defined as systolic pressure decreasing more than 30% of the basal value for more than 5 minutes. And they found that prone esophagectomy and those patients with an epidural catheter had more often hypotensive episodes. So a few patients were treated with vasopressors, and they identified that patients who had hypotensive episodes, especially those who were treated with vasopressive agents, had a higher chance of leak. So So untreated intraoperative hypotension is associated with postoperative anastomotic leak. The mobilized gastric tube has a limited blood supply from the right gastroepiploic artery, and the blood flow at the distal segment can be decreased. Hypotension may further compromise perfusion of the gastric tube and thus can increase the risk of anastomotic leak. Now, another American study said that the use of vasopressors during esophagectomy is not associated with increased risk of anastomotic leak. Now, this was done only on open Ivor-Lewis esophagectomy, and they identified that only body mass index was significantly associated with increasing odds of postoperative anastomotic leak, an increased BMI. So, hemodynamic management, we would avoid fluid overload. We would have hypotension during esophagectomy, especially due to compression of the IVC, during the manipulation of the esophagus, compression of major intrathoracic blood vessels or the heart or arrhythmias, and the preferred vasopressor of choice would be norepinephrine. So intraoperative complications could include hypoxemia, hypotension, and arrhythmias. Now, this was a global study which determined all the complications which were associated with esophagectomy. It was done all around the globe, included an Indian author as well. And we found that pneumonia was seen in 15% of patients. Esophageoenteric leak was seen in 11% of patients. Atrial arrhythmias requiring intervention was seen in 14.5% of patients. Thromboembolic complications were seen in 5%, and infection was seen in 14.2%, while wound infections requiring opening wound or antibiotics were seen in 0.7% of patients. So this particular, the earlier study said that 28% of 2,704 patients had severe respiratory complications, 15% had pneumonia, and 7% had respiratory failure. Now, another study, which was done in Dublin, was on this neoadjuvant chemoradiotherapy, mainly the cross radiotherapy. It was a retrospective single-center study on consecutive patients who underwent TTE and THEs, only the open surgeries only, and not on minimally invasive surgeries. Identified a change in pulmonary function test and DLCOs after neoadjuvant chemoradiotherapy, and they analyzed it using linear regression on 228 patients. So they did a baseline PFT and DLCO, and then the patient underwent chemoradiotherapy, and then again they repeated a pulmonary function test after 4 weeks, and then the surgery was done after 6 weeks. They saw the comprehensive complication index and quality of life after 1 year. They found that 14.8% decline in DLCO after CTRT. So the reduced post-CTRT DLCO significantly predicted respiratory failure, comprehensive complication index, and had poorer quality of life after 1 year of surgery. Now coming to robotic assisted minimally invasive esophagectomy. So we need to be familiar with the Da Vinci Robo, and we need to be familiar with one lung ventilation with the TLT. Patient positioning and prevention of complications such as nerve crushing injuries while the robotic system is used. We should also recognize the hemodynamic effects of CO2 insufflation in the chest. And there is always a potential for conversion to an open thoracotomy or an open procedure in the abdomen. So there is limited access to the patient in Grammy. All lines need to be placed pre-op. It is impossible to place the lines once draped and robo is stopped. So we need to secure the tracheal tube, the IV line extensions, the arterial lines, the NG tubes well beforehand, and use an intermittent pneumatic compression boot, which is mandatory. Use clear head drapes, appropriate patient positioning, paralytic infusions using NDMR and monitor TOF, CO2 insufflation to the upper hemithorax, and usually temperature is well maintained in a ram. There is always a chance that DLT can migrate, and that can cause patient desaturation. So during RAMI, there is CO2 insufflation through sealed ports causing positive intrathoracic pressure of 5 to 10 centimeters of water. This can cause better operating conditions by encouraging lung deflation and flattening of the diaphragm. However, this can cause cardiovascular instability, leading to hypotension and bradycardia. And these are more profound in patients who have poor left ventricular function or hypovolemia. So complications due to excess gas insufflation. There may be gas embolism, so there can be sudden hypotension. We would have to stop CO2 insufflation immediately. There can also be a damage to the contralateral pleura, causing CO2 entry, making ventilation difficult. So there can be desaturation, hypotension, and subcutaneous emphysema. So we'll have to stop CO2 insufflation in this case as well. So a clear head drape would mean allowing direct visualization of the patient. So in a patient for RAMI, we'll have multiple changes in position. So essentially, we induce the patient is supine, then the patient is placed prone or left lateral decubitus. And again, for laparoscopy or laparotomy, the patient is placed supine. And we will also have to exchange DLT with a single lumen tube after the thoracic dissection. So we'll have to keep our airway equipments ready. Now, early postoperative complication in any esophagectomies would include postoperative pain, splinting of the injured hemithorax, which would cause postoperative pulmonary complication. There can also be chyle leak, recurrent laryngeal nerve palsy, and anastomotic leak. What is functional gastric emptying disorder? So more than 50% of patients after esophagectomy can have functional delayed gastric emptying. This happens because of the removal of the gastric wall during esophagectomy. It signifies that they are always at risk of aspiration, and patients with 40% incidence of reflux esophagitis inherently have FTG. Now, what about chyle duct injury? This would prolong the length of stay. There can be tissue. This essentially happens because of tissue damage during surgery. So chylous drainage can lead to wound infection. It also leads to carotid artery exposure and rupture. So you would have to put the patient on a medium chain triglyceride diet, which directly absorbs into the portal circulation. And you will have to put the patient on TPN or fat-free diet. Another complication is an anastomotic fistula. So the common reason is the pressure of the stapling device or closure device is uneven. It results in local fracture or damage of the anastomotic mucosal layer. This you can inspect using endoscopy, and leak can occur. There can be persistent sepsis. You may need to insert a stent, which will require airway protection. Now, this particular study studied about the anastomotic fistulas. Anastomotic fistulas are more common in the neck than thoracic anastomosis. So they used a self-expandable metallic stent or endoscopic vacuum-assisted closure. Atrial fibrillation is a strong indicator of leak. CRP and lactate levels can be high during anastomotic leaks. If untreated, they can lead to an esophageal stenosis. So we would say if the patient has atrial fibrillation, always do a CT chest. So new onset atrial fibrillation after esophagectomy. A study from the Netherlands identified the causes for atrial fibrillation, which included that 77% of atrial fibrillation occurred due to infectious complications. So new onset atrial fibrillation after esophagectomy occurred in 12 to 37% of patients. So of this infectious complications, anastomotic leak was seen in 71% of patients and pneumonia was seen in 42% of patients. So if there was no infectious complication, still AF occurred in 23% of patients, of which chyle leak was one reason. So this study from China compared minimally invasive esophagectomy and open esophagectomies on a retrospective cohort of 484 patients, of which 63 patients had underwent minimally invasive esophagectomy And they found that minimally invasive esophagectomy reduced the risk of post-operative atrial fibrillation. So this is a systematic review and meta-analysis of 14 case control studies, mainly retrospective and English articles. So the population was patients affected with CA esophagus. The intervention group was RAMI and the control group was minimally invasive esophagectomy group. And the outcome was short-term clinical outcomes. They identified that the incidence of pneumonia and vocal cord palsy were significantly lower in the RAMI group than in the minimally invasive esophagectomy group. But there was no difference, no significant difference in the overall and disease-free survival, as well as short-term mortality between the two groups. And the operating times were longer in the RAMI. Now looking into the ERAs and esophagectomy. Now a few salient points. In the preoperative phase, routine use of pharmaconutrition for esophageal cancer is not currently supported. And in the prehabilitation, there is limited evidence that supports the use of exercise-derived parameters in risk stratification of patients undergoing esophagectomy. And then in the intraoperative phase, thoracic epidural should be considered as the first line of approach. Paravertebral blocks are a good alternative. Regular acetaminophen dosing as high as 4 grams per kg per day. And NSAIDs can be initiated on an individual basis. Post-operative period, antithromboprophylaxis with low molecular weight heparin together with mechanical measures should be started preoperatively and should be continued in the post-operative phase. What about the endoscopic procedures in esophageal CA? This would include the endoscopic ultrasound, endoscopic mucosal resection, endoscopic submucosal dissection, argon photocoagulation, NG-tube insertions, dilatation of the stricture, colonoscopy and endoscopy for diagnosis. Now for anesthesia for endoscopic surgeries in esophageal CA, during preoperative assessment, our goal should be to detect the risk of hypoxemia and aspiration during the surgery. So these patients can come for monitored anesthesia care, or you would have to give them full general anesthesia with endotracheal tube to protect the airway. They could always have gastric outlet obstructions, echinacea, upper GI bleeding, esophageal strictures, and pharyngeal pouch. In case of pharyngeal pouch, we need to intubate the patient in head up position. And it is always better to do a check endoscopy under local anesthesia before induction. The plan of anesthesia is a spectral array in endoscopy. It could be monitored anesthesia care, conscious sedation, deep procedural sedation, or general anesthesia with a tracheal tube. Now, the challenges faced during endoscopy would be that we share the airway. We'll have intraoperative multiple changes in position, multiple machines around, and many cases on a single day. And the field of GI, esophageal, and endoscopic sedation is very unique as patients often are sick and yet the procedure is mandatory and cannot be postponed. Now, a study from Korea identified and compared the complications between conscious sedation group and general anesthesia group in patients who underwent esophageal endoscopic submucosal dissection. However, the duration of the procedure was only 60 minutes. And they found that aspiration pneumonia was significantly higher in patients who were in the conscious sedation group than in patients in the general anesthesia group who were protected with an endotracheal tube. Our experiences in the endoscopic suite would include a bilateral pneumothorax after endoscopic submucosal dissection, new onset AF during ST dilatation, and subcutaneous emphysema after ESD due to perforation of the esophagus. Now, other procedures that a patient with esophageal CA, after esophagectomy, patients may come back to us for lung metastatectomy. Patients may come back for radiofrequency ablation of small mets in the lung and the liver in the CT room. So we will have a condition of non-operating room anesthesia, or for argon photocoagulation, or for colonoscopy. So remember that rapid sequence induction with suction to prevent aspiration or awake FOB would be the dictum in these patients. Now coming to gastric cancers. So the most common gastric cancer is an adenocarcinoma. So we also see lymphomas and cysts. Now gastric cancer is one of the leading cause of cancer-related death. So the blood supply of the stomach is from the celiac axis, while the nerve supply is from the parasympathetic, essentially from the vagal nerve. The sympathetic is from the celiac plexus. So the parasympathetic stimulation would promote acid secretion, gastric motility, and closure of the gastroesophageal sphincter, while sympathetic stimulation will delay gastric emptying. So gastric cancers, the proximal gastric cancer is more common than the distal one. Patients can present with unexplained weight loss or chronic GI bleeding. They can also have persistent upper abdominal bleeding, iron deficiency anemias, and obstructive jaundice. So the patients who have gastric cancer will also be given neoadjuvant chemotherapy 3 cycles, and then they wait for 3 to 6 weeks, they have gastrectomy, and then 6 to 12 weeks later, they will also have 3 cycles of chemotherapy. So the preoperative assessment should include all regular multiple comorbidities that they have, and if they have stopped smoking or not, we have to advise that. And risk for postoperative complications will increase with a BMI less than 18.5, or if they have 20% weight loss and hypoalbuminemia. So we'll also have to note down chemotherapy-induced toxicity, mainly the neuropathies. Surgery on any patients with post-chemotherapy neutropenia is usually postponed for 3 weeks. So the investigations would include the usual profile and the endoscopic ultrasound and post-chemo echocardiogram. So the surgeries in gastric cancer would be a wide array of surgeries. And you will see that the palliative gastrectomy is usually done in a bleeding metastatic tumor, in whom you will need to keep blood ready. So the preoperative preparation of patients who are coming for gastric cancer would include treatment of H. pylori infection, correction of anemia. You will also need to put in a feeding jejunostomy or place an NG tube in case of gastric outlet obstruction, and optimize nutrition. And spirometry. It is important to initiate and continuously encourage the patients to do spirometry in patients who are coming for gastrectomy. The anesthetic management of gastrectomy would include, again, the thoracic epidural anesthesia, pre-oxygenate the patient. If you need to give rapid sequence induction, pre-oxygenate, and then the usual general anesthesia with an endotracheal tube. Now, thromboprophylaxis would mean low molecular weight heparin and antithromboembolic stockings evening before surgery, and use scarf compression devices intraoperatively. It is important to provide good postoperative analgesia. You can also use erector spinae block or rectus sheath block bilaterally. Postoperative complications would include pain due to surgery, could be because of the drains, could be because of intercostal tube drains, which are also placed during an extended total gastrectomy. So pulmonary complications, so you will see that pneumonia is common with advancing age, prolonged surgery, or in patients who have COPD. Long-term complications, many patients can become anemic because iron needs to be in an acidic environment to be absorbed, and B12 supplementation will also be needed. What about robotic gastrectomies? It needs reverse Trendelenburg position. The robot is docked above the patient's head with the head of the bed rotated away from the mission. There is limited access to the airway. There is always risk of injury to the head and neck. Patients can come back to us for emergency re-exploration after gastric surgery. Could be because of bleeding from the splenic or the common hepatic artery. And you will have to place your IV lines quickly. There is a prevalence of bleeding of 0.6%. The post-operative period can be very strong. Now, what are the functions which are lost after gastrectomy? So the tonic contractions of the lower esophageal sphincters that usually prevents a gastroesophageal reflux is lost. Pancreatic enzyme secretion that is enhanced by cephalic vagal stimulation and the presence of food in the antrum and duodenum. This function is lost with a subtotal or a total gastrectomy. And after gastrectomy, there is no control over the rate at which food enters the duodenum. And this can lead to dumping, whereby fluid shifts into the GI tract, giving symptoms of hypovolemia. The production of intrinsic factor is also lost. Patients can have sepsis mainly due to anastomotic leak. The incidence is around 1.6%. There can be early leak as early as 72 hours or within 7 days. So it is important to detect the source of sepsis and control infection because the mortality rate is as high as 50%. Now, patients can come for endoscopic procedures in gastric cancer as well. It can be diagnostic, therapeutic, and palliative procedures. Now, diagnostic would include extent of the tumor to identify the lymph nodes, can be therapeutic like the endoscopic mucosal resection or endoscopic submucosal dissection, can also come for endoscopic control of bleeding, and palliative procedures like placement of self-expandable metallic stents for gastric outlet obstruction or a PEG for CA esophagus or inserting an NG tube or an NG tube. Thank you. Do join us for OASIS 2023 that's going to be held in September at Ramada in Chennai. Thanks a lot for hearing. That's all from me, ma'am.
Thank you, Nivedya. I think you covered most of the salient features of anesthesia challenges in esophageal and upper GI tumors. Do you want to say anything about the HIPEC, which we have been doing for, stomach? Like, the high-grade tumors where HIPEC is also being done recently in our center, but I would like to know the other, experts' experience with that and also the outcome. Jyotsna, ma'am?
Yes. Yeah. Did you do HIPEC recently in your center for esophagectomy?
Not for esophagectomy, ma'am. Following gastrectomy.
For other. Okay, gastrectomy. So what was your experience? Did you do anything different than other HIPEC surgeries or?
No, ma'am.
Nothing.
So,
yeah.
So it is like any other HIPEC surgery, whatever precaution you take like this, no?
Most of the cases doesn't require invasive lines or monitoring. We could just get away with the peripheral venous access and not much fluid shifts are happening, and most of the surgeries are very short duration also.
Okay. So for HIPEC surgery, you don't put any invasive access like
not for gastrectomy, ma'am. Not
for
particularly for HIPECs following gastrectomy. Not many cases, but few of them we have done.
Yeah. Maybe for gastrectomy, you may not require. Yes. So any other question coming in the chat box or no?
No, I don't see any questions in the chat box now.
Ma'am, no questions have come yet.
Okay.
Yeah, no,
okay.
I cannot see any
So I just want to know about what is your complication rate in your hospital whenever for esophagectomy particularly?
So in esophagectomy, ma'am, the most common complications, the surgical complications would be recurrent laryngeal nerve palsy. That is more common. It comes to around, say, 20% or 25%. Relatively, esophageal leak comes 1 in 10 patients. That's what is the rate. And other than that, you can also have chyle leak. That is another complication that is common in the esophagectomies.
Yes. So how did you manage? Suppose the patient comes after within few days with chyle leak. So in that case, how do you manage this patient?
So the patients are placed on a fat-free diet, and we are given this medium chain triglyceride, which actually reduces the, which is actually taken up by the portal circulation. So it reduces the formation of chyle. And you actually diagnose the chyle leak when you look for more than 150 grams of per deciliter of triglyceride. It would mean that there is chyle there. So for which you give the medium chain triglycerides or give TPN to the patient and put him on a fat-free diet.
Yes. Any other recurrent of palsy you said quite common? You got a recent, how many percent you said? 20% or?
Yeah, around 20 to 25 because it's more common in the neck, ma'am. The recurrent laryngeal nerve injury is more common in the neck surgery.
So is there any, but yeah.
In minimally invasive approach, ma'am, esophagectomy, not in the open, I guess. Is it not?
No, in either ways, the commoner cause practically from the surgeons, the place where the recurrent laryngeal nerve gets damaged is in the neck. That's because the neck incision is smaller and it is difficult to identify the nerve in the neck. So it is very commonly injured in the neck, even if it is THE or TTEs, or if it is a minimally invasive esophagectomy. Ultimately, the anastomosis in the neck, they have to do using neck dissection. That is where they can injure the nerve.
But it is not that common in case of IVLs, no? When thoracic incision and laparotomy, these two are there. The rectum is not seen. It's only seen in case of neck incision.
Yeah, true. But more commonly in our setup, we do this triple incision surgeries. So we do a VATS or a RAMI. We do a laparotomy, and then we do a left cervical incision for neck anastomosis. So we do this often, the triple incision surgeries. We don't do a thoracotomy, but we use a minimally invasive RAMI or a video-assisted thoracoscopy surgery for the thoracic dissection.
Okay. So for VATS and all, you use double lumen tube or bronchial blocker? How to isolate lungs?
So we use the DLT, ma'am. Most commonly, we use the left double lumen tube to isolate the lung.
Why? Any particular reason for that? Or
nothing. That is the practice that we use. Of late, we also for RAMI, we use the normal endotracheal tube. If the patient is placed in the prone position, they use CO2 and they go further. They ask us for low tidal volumes and we don't isolate lungs.
Okay, you don't isolate. But because why I want to know, because esophagectomy is at the end or in between, sometimes you have to put you can change over when they go to laparotomy, you can just remove the bronchial blocker and go on with the single lumen tube. So it is easier to handle the cases like this. Okay, there's some question, I think.
Yes. Somebody has written, I would like to state that stomach hypec is done only when PCI is less than 10. So peritoneal resection is very less, hence fluid shifts are less. So invasive lights are not must. Yes.
Yes.
Yes. Yeah. There is another question. Or DLTs and OLB always imperative in esophagectomies? That is from Dr. Arvind. Would you like to answer, Nivedita?
Ma'am, you can answer, ma'am.
Yeah. Go ahead. Okay. Not like just now we had discussed, it is not always mandatory for all esophagectomies. Depends on the approach. Like for RAMI, in the beginning stages, we used to insert DLT and OLV where the position of the patient would be in left lateral and the arms will be abducted. So that was quite difficult for the surgeons also. Later, they had changed the approach, or they positioned the patient in prone and they found it very comfortable or convenient. So in that case, we had also changed to single lumen tube. And then we opted for low tidal volume and low peak strategy. So not for all esophagectomies, you need to have DLTs and OLP.
Yeah.
So I don't see any other questions, ma'am.
Yes. So if everything is covered probably, so there's no more questions. So we can close this then, I think.
Okay.
Okay.
Yes,
Thank you very much.
Thank you.
Dr.
Thank
Punita
you,
and Dr. Nivedya. It was very nice and comprehensive talk. We all enjoyed these things. This is a very nice, informative talk. Okay. Thank you all.
Thank you so much.
Thank you all. Thank you. Bye.
Bye.
Thank you, ma'am. Lastly, we would like to say in the Q&A box also, we have received a few questions, 2 questions. That is from Dr. Aravind Narayanan also. I would request the speaker doctor or the coordinator ma'am to kindly address the question.
No.
Yeah,
these were addressed before already.
We addressed it.
Okay, ma'am. Thank you.
Thank you.
Okay.
Thank you, ma'am.
Thank you. Bye.
So I would like to thank all the doctors for giving us this opportunity to host this session. And with all your permission, then we are signing off for today. Hope to see you soon at our platform for the next interesting topic. Thank you, dear doctors, for your valuable time and sharing such valuable insights. Thank you, everyone. Good night.
Thank you.